We are going to share with you an implementation science research where we looked at mentorship as a tool of improving quality of care for patients with PPH. This afternoon, the presentation that I'm going to share is entitled Empowering Change, Mentorship to Improve and Sustain Quality of Care for PPH. Best practice for mentorship approaches to improve provider skills and competencies are poorly understood. What we have learned is that mentors need adequate training and support as educators. Secondly, simulation is a useful educational tool that provides real-life scenarios to practice emergency obstetric events. Thirdly, mentors and providers welcome more structured mentoring activities. And finally, there is interest in a pathway for professional development for providers and mentors. Mentorship approaches need to align with core principles of mentorship, and these include mutually beneficial, relationship-based, and they are highly personalized. If we look to the background, we see that providers are often challenged by limited opportunities for formal training, high turnover, and under-prioritized continuing education. Training often takes the form of large centralized didactic trainings at district or capital levels, prioritizing senior and management staff incentivized with PDMs. Rural providers can feel marginalized and at a disadvantage in a primary healthcare model that is largely decentralized. If we look at the evolution of skills strengthening models, we find that they are mutually beneficial, they are relationship-based, and then they are personalized. Let's look at traditional supervision. In this, the skills, it's a skill-focused activity, and it is most of the times disempowering for the learner. Now, supportive supervision, you get things start getting better, where skills and professionalism focused start to emerge, and then there's also an aspect of power sharing. In mentorship, you find that is based on mutual trust and respect, that is between the learner and the mentor, and it is empowering for the learner, and it is also career focused. Our mentorship intervention in terms of design and implementation took place from October to December 2020, and I'll talk about them in the two countries, Madagascar and Malawi. If you look at the mentor training, in Madagascar, it was a 2-day hybrid training with master trainers remote and mentors together, and there was a 1-day follow-up training. While in Malawi, it was a 5-day in-person mentor training. In terms of the dose or frequency, in both cases, there were 4 facility-based simulations. In terms of content, in Madagascar, there was a simulation, a virtual mentor, provider support tools, which were reinforced during mentor visits. And for Malawi, there was simulation, communication, and teamwork training. In terms of mentor support, there were 3 coaching sessions, and they utilized the video library of simulation procedures in Madagascar. Whereas Malawi used the 3 coaching sessions, utilized the video library of simulation procedures, WhatsApp mentor group with Pronto master trainers, and a video review of simulation fidelity with feedback. Now let's look at the Malawi mentor-led simulation scenario. There were 4 simulations. 1 was normal birth of a vigorous baby. 2, normal birth of a vigorous baby and immediate postpartum hemorrhage. The 3rd one was severe postpartum hemorrhage, which was due to atony. And the 4th one, it was a COVID-19 positive patient with a spontaneous vaginal birth of a non-vigorous baby. In Madagascar, there was a normal birth of a vigorous baby simulation. Another one was normal birth of a vigorous baby and immediate postpartum hemorrhage. The other one was severe postpartum hemorrhage due to atony, and then severe PPH with shock due to cervical laceration. Now let's look at Madagascar in terms of the virtual mentor with the simulation remote training. There was an innovative mentoring tool for PPH case simulation at frontline health facilities, and also a digital decision support tool in the form of a hands-free. This was a voice application on a tablet. You can see it as a picture there. And they also used provider tools. The tools were as follows. There were task badges. These leverages family members to support overburdened providers, a source of pride and responsibility for family members, and also facilitates more frequent postpartum monitoring. The second tool is a ultrasonic timer. This is a visible reminder of oxytocin administration, and it draws attention to 1 minute window. And it gives immediate feedback on timeliness, and also stores timestamp for record keeping and full data. The last tool is glow in the dark algorithm poster, which provides easy to follow reminder of protocol in a moment of panic, attracts attention during night hours, and makes PPH preparedness top of mind. Now let's look at the results. For the Malawi scenario, we found that simulation and team communication sessions increased provider PPH knowledge. If you look at the graphs there, PPH knowledge scores in control and intervention districts. Lilongwe was our control district, and Zomba was our control district, our treatment or intervention district. If you look at the mean scores, knowledge increased by 14% in Zomba, which was in the intervention district, and it was statistically significant. And there was a decrease by 9% in Lilongwe, which is our control district, and it is also statistically significant. The difference in difference analysis also supports this finding. Now, if we look at teamwork and communication sessions, there was increased provider PPH self-efficacy. Self-efficacy scores by control and intervention districts, you can see that there were significant increases in self-observed in both intervention districts. Significant improvement from baseline to endline, and that was statistically significant. And there were significantly higher scores in Zomba compared to Lilongwe at endline. The difference in difference also maintains the increase. The Malawi simulation implementation results in terms of provider feedback and acceptability and feasibility, 88% found the simulation activity to be very useful for better managing next case of PPH. 96% would highly support the use of pronto learning sessions as a training tool in the future, and 97% would welcome pronto learning sessions to others, and 98% feel that their team has benefited from having this training. In terms of qualitative or narratives from the participants, they made positive comments. It was like putting me in a complete situation on how to manage patients on PPH. It has acted as a reminder on how to give quality care. It reminded us that communication is very important, since we can manage a patient if we are communicating. These were 3 different participants reporting on the positive aspects of the simulation. If we look at Madagascar, you find that knowledge and self-efficacy scores also increased among providers that were exposed to the intervention. So here you have the pre and post scores, which are showing knowledge increase. And in terms of self-efficacy ratings, you can also see the increase in the rates of self-efficacy. In Madagascar, they used a visual mentor, and in terms of feedback on the acceptability and feasibility, 74% reported that they would like to use the virtual mentor for actual patient care in the future, while 84% really enjoyed learning with the virtual mentor, and then 87% believed that the skills learned would be useful in helping patients. In terms of qualitative results, provider 1 said that the virtual mentor is very helpful, because if I am alone at the job and a PPH case comes up, the virtual mentor is like a colleague. He's the one who helps me. Another provider said that what we did broadened my knowledge even more. I made an innovative gesture after this training because I remembered in my head some good advice from the virtual mentor. In terms of sustainability for Malawi, WhatsApp channel continues today, even after so many months after the intervention has finished. Kamuzu College of Nursing led the mentor training, has potential to continue growth of existing mentors to mastery. I recommended building on this approach for training and supporting mentors and defined mentor activities, and also communication and team training is highly valued. For Madagascar, interest and will to scale both tools and simulation training approach is there, and will require additional simulation education, educator training and support, and a virtual mentor will require software modification for a greater usability, and 80% of the timers had been used in the previous 24 hours. Qualitatively, providers said that we are always ready to inject the oxytocin as soon as the baby comes out, but there may be difficulties in the delivery, and then we get distracted. That's what the timer is for. Another provider said that I know this by heart, but sometimes I panic. I might forget something, and that is the GLOW algorithm, will remind me. For the COVID-19 adaptations, there was a hybrid training of mentors, and there was remote coaching and support, and it accelerated development of simulation education library. For Malawi, the development of COVID-19 specific simulation scenarios for PPE, screening, prevention, and management, and rapid review and fidelity assessment of simulation training videos with mentor feedback. Pilot testing of innovative voice-activated mentor support tool for PPH training in a remote setting, that was in Madagascar, and there was also instructional videos for introducing provider tools that were developed. In terms of summary for the results, in Malawi, provider knowledge and self-efficacy improved in simulation intervention facilities compared to the control facilities, both at baseline to end line. And participants in the simulation sessions found them useful, acceptable, and feasible to conduct routinely in the facilities. And for Madagascar, provider knowledge and self-efficacy improved among participants in the virtual mentor and provider support tools, interventions, pre- and post-training evaluation. Participants also responded favorably to the intervention and appreciated the introduction of innovative tools to support PPH care in these remote settings. Key takeaways about mentorship and simulations: they are mutually beneficial learning for mentors and mentees. Simulation sessions were well attended and received positive feedback from providers. Providers overwhelmingly expressed interest in additional simulation sessions, and simulation allowed for non-hierarchical learning and self-reflection and behavior. The approach empowers participants. Team training and provider support tools contributed to self-confidence through reinforcing clinical knowledge and team communication. Emergence of career development opportunities: mentees gain the skills to become mentors, while mentors gain additional skills in creating a non-hierarchical and supportive learning environment.